Bismillah, salatu salam ala Rasulullah. Today, inshallah, I will speak about Choose Wisely initiative, specifically related to radiology domain. So, brief introduction on Choose Wisely initiative. Choose Wisely initiative have been adopted and launched by American Board of Internal Medicine Foundation in 2012. It begins with small societies. Only 9 specialties were participated in that initiative. It offered 45 examples of tests or treatment that were commonly used in their field but lacked strong supportive evidence. Between 2012 and 2023, there was significant engagement in other specialties and reached more than 80 societies by 2023. Here are some examples related to imaging specifically. Example, Canada, the Choose Wisely in Canada with national imaging guidelines. In UK, emphasized on shared decision-making using NICE guidance. And in Australia, they focused on public education and appropriate imaging. In Saudi Arabia, it was this initiative, the Choose Wisely, is launched by Ministry of Health in 2019 and led by the Saudi Patient Safety Center. So first, why radiology in this initiative? It has been noticed that one of the many causes of raising and increasing healthcare cost in medical care in general is related to unnecessary tests and procedures. And one of the most commonly requested exams is radiology exams. So medical imaging is often overused, leads to unnecessary first radiation, cost, and patient and anxiety. Choose Wisely aims and helps to guide appropriate imaging use. So what are the economic impact of overuse in radiology? Usually it contributes significantly to raising healthcare costs. As mentioned, these costs are coming from directly, cost of the equipment, installation or staffing, or the radiologist who interpret these imaging findings. Unnecessary CT and MRI cost billion globally each year, and there are indirect costs related due to follow-up tests with this imaging and sometimes incidental findings that were picked during imaging these patients, and sometimes it's related to patient anxiety. So I'll give you a sample of most common ordered exams. That we think there is an overuse. Example, CT head. In emergency, usually the cost is $500 to $1,000 per scan. MRI lumbar spine without contrast, the average is between $1,800 to $1,500 per scan. And it is estimated that 20 to 30% of those scans could be avoided. Choose Wisely aims to promote high-value care. Also, not to forget the radiation exposure, specifically with the CT and X-ray and other radiation-emitted imaging modalities. There is increasing risk of unnecessary exposure to radiation. So if we compare the chest X-ray, it's one of the lowest radiation emitter. Lowest radiation absorbed dose comes from chest X-ray, about 0.1 millisievert per exposure. If you compare it to the CT abdomen, it's almost 100 times more. So CT abdomen is the absorbed dose is 10 millisievert per acquisition. So also not to forget, if the patient has more frequent follow-up, this will add to the cumulative absorbed dose for frequent imaging for the patient. Also, we need to focus also to reduce the imaging, improve imaging protocol to reduce the absorbed dose for the patient. So there isn't, the risk of overexposing those patients to unnecessary radiation. So up to 30% of imaging is unnecessary. This is according to Organization of Economic Cooperation and Development. This is a report was in 2020. I'm sure it will be now higher. So CT usage has doubled in many countries over the last decade. And our data in here in cluster 2, it shows an average 10 to 15% growth annually in the requested CT. So Choose Wisely initiative, of course, not 100% reduction, but it's aiming to reduce on average 7 to 20%. This is the maximum they achieved with this initiative in most of the good centers that achieve almost 20% reduction in necessary exams. MRI overuse associated with incidental findings ranging between 20 to 40% of the scan. That is not related to patient pathology, but sometimes it will lead to overdiagnosis, over additional indication, and unnecessary follow-ups. That also will add to cost of the healthcare cost. Here are some of the literatures. Example, Levin and et al. In 2017. With this, with the application of Choose Wisely, they have achieved 7% reduction in inappropriate imaging. Mafi and his team showed a small decrease in low-value care post-campaign. In Canada, Bataille and his team, they showed mixed adherence in Canada. All of them, they noticed that awareness has improved post-application of Choose Wisely, but adoption by the clinician, it takes longer time and slower adoption of these concepts of Choose Wisely. So what are the barrier of implementations? Sometimes lack of clinician awareness or motivation to participate of these new in the initiative of Choose Wisely. Sometimes defensive medicine practices, they don't want to hide. They want to be exposed to legal if they don't have investigated this or add this regimen in their imaging, their protocol for imaging. Sometimes just to satisfy patient needs, or sometimes the patient comes directly to the clinic, they are expected to have imaging with MRI or CT, so they are trying to satisfy patient needs according to, the patient, satisfy patient expectation. Another major issue, which is inconsistent guidelines across the healthcare system. There are variability between the teams, whether inside the hospital or at the national level, or sometimes country to countries. The guidelines are inconsistent for a specific pathology, when to ask for imaging, when to ask for follow-up. So our initiative in cluster 2, we divided in phase 1 and 2. Now we are at the end of phase 1. We focused on overuse of MRI in King Fahd Medical City. Also, we focused on overuse of CT in emergency admission type for 2 hospitals, King Fahd Medical City and Prince Fahd. So our initial audits revealed that high CT ordering in emergency department, frequent use, most of the common unused or not indicated exams are related to minor head trauma, sometimes abdominal pain, sometimes related to dizziness. Our objective to implement clinical decision support and education to the referring teams. Also, we have baseline metrics and collected for benchmarking, and we are achieving good achievement by end of phase 1 of this initiative. So I will mention some example, real life example CT in emergency in our practice compared to others. So we noticed there is a lack of adherence to clinical guidelines. So in head trauma, once ex-physician is covering that shift, he will ask for more CT compared to an ex-colleague with the same specialty. So that there is lack of adherence to guidelines, or there is no standardized practice between the teams. We have worked with our colleagues from emergency and other departments to standardize their ordering rules. Example, Canadian CT head rule for head injury is implemented now, and we have good achievement with this. One of the reasons also, pressure to quick diagnose and discharge the patients. Yeah, the ER physicians are in pressure to have good turnover of for the occupancy of the patient and journey of the patient in the ER. So sometimes they tend to shortcut this journey by ordering a CT to reach a diagnosis whether positive or a negative scan to discharge or admit the patient to the inpatient ward. And sometimes it is related to defensive medicine practices. Also, we noticed that sometimes the reason for these requests and frequent necessary exams due to lack of awareness of radiation exposure risk among non-radiologists. And nowadays we noticed, and this is general observation, that most of the physicians make it, they rely more on imaging and they show high reliance on CT in emergency settings for quick diagnosis. And sometimes, as I said, it's for a minor indications like minor head trauma or abdominal pain or disease, they jump in for diagnostic modalities that can be avoided, like CT. So back to our example, minor head CT trauma, we worked with them to assess risk level. First, use validated tools like Canadian head trauma rule to determine their needs for imaging. Also to consider patient factors like age, anticoagulation status, and mechanism of injury, whether the patient is involved in major, like rollover injury, accident, or just minor foot injury. Implement observation. We monitor. We suggest our colleagues to monitor low risk patient observation for certain period. If there is no good clinical indication, observation is enough. Also, we need to protect certain age group, example pediatric. They are more sensitive age group for radiation. So we tend to restrict or guide them not to order high radiation emitting procedure as a first line of imaging. We'll move to other, strategy of implementation because of the time. So we worked with our colleagues in the hospital to have a solution, embedded solution like clinical decision support within the HIS, the health informatics system. Also, we have run many educational activities for the clinicians and patient as well. And we have created auditing and feedback system within radiology network. These dashboards are 24/7 updated to have a feedback system for our colleagues, and which has been implemented between us and ER, and our ER colleagues have an access to this dashboard to see frequency of unnecessary exams. Also, we have we encourage promote interdepartmental and interspecialty more collaboration to improve to achieve our goals. So, example, in Canada, they used the clinical decision support tool to have a better guide VCT, and they achieved 20% reduction in CT scan for minor head trauma. And physician feedback improved the compliance. So also not to forget, one of the areas is the emerging role of AI. AI can help identify low-value imaging orders and can show predictive models integrated into clinical workflow. Actually, within the newer models, these AI tools can read from the patient chart and suggest which modality can be useful to reach the patient diagnosis. Another example is pulmonary embolism, one of the most common ordered exams in the emergency. We recommended to have standard, and most of them they adopted the WELL score criteria for validated tools, and they should not go immediately for CT scan in low risk or intermediate risk patient. They can only go for the dimer for positive scans or negative to include them for the CT. So again, for the head trauma, evidence showed that if it's minor head trauma, the yield of the CT is very low, less than 10% of the scans will be positive. So other area of interest in our initiative is MRI overuse. we noticed most common ordered tests are related to back pain, headache, and sometimes joint pain, and does not change clinical management of the patient, or does not add to the patient management or change the patient management. Sometimes, as I mentioned in the beginning, it can lead to overdiagnosis, can pick incidental findings that are most of the time benign and does not relate to patient complaint. Choose Wisely advises against MRI, not to go for MRI without a red flag or for a specific diagnosis. So unnecessary MRI can create an anxiety for a patient as well as increasing health care cost, and we recommend monitoring clinical status may be more appropriate in some cases, not to go directly for advanced imaging like MRI. So I would like to move quickly because I'm running out of time. Example, low back pain, one of the second common indications in MRI. We worked with our colleagues from spine surgery to have a categories for when to request an MRI for spine. Example, if there is severe trauma or neurological deficit or suspected infection or history of cancer. Most of the time, conservative management is more appropriate for the patient. For example, physical therapy, pain management, and activity modifications. And this aspect, I'm sure Dr. Hani will speak in details about it in next talk. So in our initiative, we have created departmental reviews and case audit between us and most referring team, which has neuro, spine surgeon, and orthopedic. And we have done many educational workshops for the referring physicians. Also, we have integrated MRI request checklist for certain procedures, and we are adding more and more with time. Also, we are monitoring repeat imaging pattern over time. We monitor how frequent patient is asked to do follow-up during his treatment cycle. In our phase 2, we are planning inshallah next year to include other modalities and focus on other areas like routine X-ray in ICU and other preoperative unnecessary imaging. Because of the time, I think we'll come to the recommendations. Our recommendation is to avoid imaging for uncomplicated headaches. Most headache resolves without intervention. No imaging for low back pain without red flags. Conservative treatment is the first line approach. Avoid CT for minor head injuries in low-risk patient and use the validated clinical decision rules. Don't image suspected PE without appropriate criteria and apply clinical scoring system first. And skip routine follow-up imaging for stable patient condition and avoid unnecessary radiation exposure. Just to conclude, choose wisely, reduce unnecessary imaging. Global experience show variable adaptation and outcomes. Sustainable success requires system-level engagement. And thanks.
Thank you, Dr. Mohammed, for providing such valuable and formative insight. Now moving to Dr. Hani, please welcome Dr. Hani Al-Abbad. Dr. Hani, can you share your screen?
السلام عليكم. الصوت واضح؟ السلام عليكم.
وعليكم السلام ورحمة الله وبركاته. الصوت واضح دكتور هاني.
شاشة ظاهرة. Is the screen full? The view is okay?
Yes, you can start, Dr. Hani.
طيب. السلام عليكم جميعا ومساء الخير. Thank you for attending this session talking about choosing wisely. I will specifically focus my talk on the implementation of the concept of choosing wisely within the musculoskeletal physical therapy domain. As Dr. Muhammad mentioned, as a background, the origin and the start of Choosing Wisely, just to reinforce the information, Choosing Wisely is a global initiative that aims to reduce unnecessary medical tests, treatments, and procedures. Initially, it was launched by the American Board of Internal Medicine Foundation back in 2012 and has since been adopted by numerous healthcare organizations worldwide. Why does it matter? For many reasons, including reducing unnecessary tests and procedures, obviously. And in many research literature, it has been estimated that up to 30% of all medical services, unfortunately, is considered unnecessary. So that's why Choosing Wisely matters, to encourage healthcare providers and patients to engage in conversations about shared medical decisions. This will ultimately improve health outcomes and will ensure sustainable utilization of healthcare resources and reduce health-related cost. So overuse is defined as the provision of a health service like a test, procedure, treatment that has no net benefit or could potentially cause harm. Where the primary aim of Choosing Wisely is to facilitate healthcare professionals and patients to question the unnecessary utility of healthcare resource. So as we can understand, it's not only the responsibility of healthcare providers, also this is collaborative work. Even patients have a role in minimizing the overuse by questioning healthcare providers whether a provided medical service is really necessary for their health condition. Choosing Wisely campaign has come about because of three key concerns: medicalization of normality. As Dr. Muhammad mentioned, many tests could show incidental findings that may not be serious, which lead to overdiagnosis and ultimately lead to medical consumerism. Now I will be talking more specifically about musculoskeletal disorders or condition. Why does it matter? Why do we think it is an important domain? First, let's define what is musculoskeletal disorders. These are a set of diverse conditions that affect the movement system, including bones, joints, muscles, and other connective tissues. These disorders may result in pain, movement restriction, and physical functional loss. Why does it matter? Because of its high prevalence. Different resources have shown an average of 30% prevalence, with a range between 13 up to 47% of whole population, which account to about 1.7 people worldwide having a musculoskeletal problem. Although it may be overlooked as non-serious medical problems, but on the other hand, it is considered the leading contributor to disability worldwide. For example, low back pain has been shown to be the single leading cause of disability in many countries. For example, in the United States, when it comes to medical spending, musculoskeletal conditions represent 1/6 of all spending related to healthcare, and is the top cost driver of healthcare spending. In Saudi Arabia, unfortunately, we don't have recent epidemiological studies or reports about the prevalence of musculoskeletal conditions, but some evidence from old reports have shown that movement-related problems account for the second most reason for visiting primary healthcare centers or outpatients, accounting for 1 million to 2 million visits, respectively. Talking about the financial burden in the United States, for example, the total cost, including healthcare cost and lost worker productivity of musculoskeletal conditions, surpass all other chronic medical conditions, including diabetes, cancer, and heart disease. Here, as you can see, the average is $600 billion is the cost, where some studies have shown a range between 400 up to $900 billion spending as a direct or indirect cost. Here we also can see the increasing cost in the past decade from 2010 and until 2019. The direct medical cost for musculoskeletal care has been doubled, although there is no clear evidence whether this spending have yielded or resulted in better outcomes. Globally, we can see also a very big cost responsible for musculoskeletal health spending that accounts for $2.1 trillion, which represent 1.4% of global GDP. And here you can see the most common musculoskeletal conditions that drive this spending, including low back pain, neck pain, osteoarthritis, etc. So where does this spending goes to? Reports have shown that most of the medical cost goes to unnecessary medical procedures, including surgical, starting with unnecessary diagnostic procedures, like, as Dr. Mohammed mentioned, overuse of imaging and overdependence on imaging as a first line to make a diagnosis for musculoskeletal condition, which is not recommended by majority or of recent guidelines, as some abnormalities seen in imaging may not indicate a pathology or serious problem and does not require surgical intervention. This leads to unnecessary treatments, including passive conservative management options, or overdependence on these management options may offer some short-term benefit, but not a long-term resolution. Also, commonly, overuse or overprescription of medications have been shown to be also one of the major drivers of the economical burden of musculoskeletal conditions. And also the unnecessary utilization of some surgical procedures that have been shown not to be superior to sham surgeries for certain musculoskeletal or orthopedic problems that can be avoided or may have an alternative conservative management options. Here is an example of how the patient access to healthcare may determine the overuse of medical resources. A large study have shown over 30,000 patients seeking care for an episode of low back pain. They tracked patients' first access or first provider seen, and the annual or spending or cost for their medical care to treat their low back pain problem. This large study have shown that access to conservative option resulted in less spending than accessing emergency or specialty department services. At the same time, physical therapy, for example, have been shown to be a solution to provide non-pharmacological and non-surgical guideline-based intervention that shows very good outcomes compared to pharmaceutical or surgical interventions, with a good immediate as well as long-term benefit. Our project at Riyadh Health Cluster 2 targeted healthcare providers as well as patients with common non-traumatic musculoskeletal disorders. The project was aiming to develop and implement educational materials to promote evidence-based physical therapy practices for the targeted conditions, which include discouraging practices identified as low-value care options and minimize the overdependence on passive therapies, diagnostic imaging, pharmaceuticals, invasive options such as injections and surgeries. This project to be also evaluated to look at the impact of this initiative on healthcare worker knowledge, attitude, and referral patterns, patient satisfaction and outcomes, and resource utilization. To make this project successful, we had to work together and collaborate with different administrations, executive administrations that provided support to ensure the implementation of this project successful and sustainable, including healthcare delivery department to improve the engagement with healthcare providers and stakeholders, information technology department to embed electronic medical record solutions to inform decision making. Also, media and individual department to produce creative content for awareness campaigns. Also, we collaborated with the research center to study healthcare providers' attitude, perception, perceived barriers, and enablers to engage with the initiative. Also, to study the impact of healthcare resources on patients' outcomes. Also, we collaborated with the Academic and Training Affairs Department to develop educational content for healthcare providers, and also Clinical Excellence, who are the sponsors of this project, to coordinate with different stakeholders. The project started with searching the medical literature, the other countries' experience, and to consider their implemented recommendations. So we searched the medical literature for the top recommendations when it comes to musculoskeletal physical therapy, choosing wisely recommendations. After that, we come up with a conclusion of the most relevant key recommendations for musculoskeletal physical therapy practice, where we directed these recommendations for both patients as well as healthcare providers. The terminology used and the guidelines for adopting recommendations as per choosing wisely should be clear, simplified, and based on the best available clinical practice guidelines. We have refined these recommendations after panel discussion with experts from the field until we come up with the top recommendations that were converted into media products to be.
ايه هلام معلش ازعجتك بس هل فصل شيء لانه ما ادري طردني انا لبنان ما ادري
في شيء. طيب, so these top recommendations have been converted into creative individual product
طلع فجأة
and has been disseminated over the hospital screens in the waiting rooms as well as in social media. In addition, we have developed specific condition educational material for patients based on the Choosing Wisely guidelines. In addition to this, the project have also been implemented into practice, where we have implemented monitoring dashboards to look and observe the top orders that has been requested for patients with musculoskeletal conditions to also look at trends and observe any deviation and to implement corrective measures. Additionally, we have implemented patient-reported outcome measures as an indicator of patient voice, also patient as well as patient-reported functional limitation related to musculoskeletal conditions, where we can track patient improvement and provide an evidence that these recommendations can lead to patient-reported outcomes. Also, to ensure ongoing implementation of these guidelines and recommendations, we have embedded the Choosing Wisely campaign as part of the curriculum of the Saudi Board for Musculoskeletal Physical Therapy curriculum, where residents will adopt these practices and guidelines along their training early in their practice. So we believe that healthcare providers can adopt these guidelines as early in their career, and it becomes easier to be implemented rather than experts in the field may sometimes find it challenging to change their practice. So in conclusion, over-medicalization burdens healthcare systems and deprives societies of resources. Controlling over-medicalization requires stakeholders, including patients, clinicians, academics, healthcare funders, media, policymakers, professional societies, to appropriately prioritize low-risk, cost-effective care over high-risk and more expensive care of equal clinical effectiveness. Stakeholders should collaborate to discuss and synthesize the available evidence, share decisions, and translate knowledge. We should not underestimate the challenge of the task, reducing the harm of medicalizing normality and avoiding the temptation to provide too much medicine, and current musculoskeletal practice depends on all of us. And key partnership between different stakeholders will ensure its long-term sustainable implementation. Thank you very much.
Thank you, Dr. Muhammad and Dr. Hani, for addressing this interesting topics. Dear participant, kindly post your questions in the Q&A icon, so our speaker will answer them gladly. Please share your questions. So, Dr. Muhammad, I have one question for you, saying, what are the difficulties and barriers during implementation of the Choosing Wisely program?
يعطيك العافية. بالنسبة للباريرز usually lack of a standardized clinical practice guidelines between the healthcare providers. And sometimes one of the barriers is to satisfy patient expectation during the visits. Sometimes all the patients come with insisting to have imaging, whether is it indicated for him, and sometimes it's not that indicated. Also, engagement of the referring specialties with you, because we are at the end we are service providers. They need to be engaged in your vision and your goal to reach this. To reach the goal of this Choose Wisely initiative.
Clear. Thank you. Dr. Hani, I have one for you, saying, is the Choosing Wisely project intended to be ongoing and sustainable, or it's a plan to operate for a limited time frame?
Of course, this is a sustainable project. It's not just a campaign at one certain period of time, and then usually people or healthcare providers may forget or start to deviate from the guidelines. This should be embedded on a daily practice and encouraged and create an ongoing discussion between healthcare providers to improve its implementation. So it becomes a work, let's say, a daily work culture. Usually, it's a new concept. As Dr. Mohammed mentioned, there could be some resistance or a need for change management strategies to convince, also to encourage healthcare providers to adopt its principles and to start engaging with patients and introducing this concept to patients. Even patients may find it a little bit unusual to ask for their opinion and to have a shared decision making by providing them with available options for their medical condition. Usually patients may depend on the healthcare provider as the expert, and his decision or their decision is expected to be a final. But nowadays, patients have better awareness and have access to knowledge everywhere. So healthcare providers should be ready to discuss these healthcare-related decisions with their patients and provide them with let's say, the more safe and less expensive options for their conditions. So this requires, as I said, ongoing maintenance and sustainable strategies to ensure that this practice has been fully implemented.
Clear answer, Dr. Hani. Going back to Dr. Mohammed, did you use specific tools such as AI solution to help you implement the Choosing Wisely program?
Yes, we are working to implement clinical decision supports. That will be like a guidance tool embedded within the healthcare information system that will guide the physician based on the entered clinical scenarios to guide which diagnostic tool can be used or imaging tool. And we're also working to adopt the best practices to be implemented within these clinical decision support tools.
Another question for you, Dr. Mohammed. What is the importance of health information system to support Choosing Wisely?
Yeah, I mean the newer version of health, I mean the health information system. Usually, it guides the physician, or sometimes it provides checklist that needs to be entered during requesting the exam. If you fulfill that criteria, it will guide you for a best procedure or best imaging tools to reach your suspected diagnosis. So it's very important, and also to make this project sustainable and to make it reflect the impact within this chart within the healthcare information system. Yes, it's very important to have the latest and updated versions of HIS.
Thank you. Dr. Hani, there is a question saying, what is the role of communication between departments for implementation Choosing Wisely?
One of the top challenges, I think, for implementing Choosing Wisely, especially in the musculoskeletal disorders, is that patients may have to visit and get medical advice from different medical practitioners related to surgery, medical or physical care. I think in many healthcare institutions, these services are fragmented, where patients may have to visit each specialty separately and may receive different information or recommendations. which make ultimately the patient get confused or unsure what is the best treatment options for their condition. So it is very crucial that relevant healthcare providers, including surgical, medical, and physical conservative specialties, have a common understanding and integrated services where patient may not feel confused or not sure which recommendation to follow. He may hear or get, let's say, controversial or non-consistent messages or advices from different healthcare specialties, causing them to be not sure what is the best evidence-based treatment choices or diagnostic procedures for their condition. So it is very important that healthcare providers adopt common clinical practice guidelines and provide patients with similar messages when it comes to their condition.
Last question for you, Dr. Hani. How the leadership support and implementation of Choosing Wisely program?
Yes, as I mentioned in the presentation, that such concept need to be adopted and supported by the top leadership. And fortunately for us in Riyadh Health Cluster 2, we received the unlimited support from the top management, the executive board, and all relevant executive administrations to facilitate the implementation of the project and to ensure that different stakeholders are aligned and work together to get the expected outcomes.
Great. Dr. Muhammad, last question for you. One reason for the excessive request for investigation is the fear or legal action. How can we empower physicians and staff to choose wisely?
To have a written, guidelines and agreed between the departments when to request, specific procedures, it will protect the physician from these legal aspects. Also, in our initiative, we worked also with the 937 to be, involved with us when they receive a complaint from the patient, to be aware that there is specific guidelines for specific procedures. Sometimes the patient complaint related to, as I mentioned, they are expecting during each visit to have imaging procedure or radiology exam, and we support our colleagues by the evidence and by the adopted clinical guidelines to protect them from any legal consequences or patient complaints. So to standardize the clinical practice and have it regulated by the health institutions will make the physician comfortable while dealing with these incidences.
Great, thank you. On behalf of the Saudi Patient Safety Center, we would like to thank you, Dr. Muhammad and Dr. Hani, and the audience for their active participation. As a part of the Saudi Patient Safety Center effort to provide you with a timely topic and interesting speakers, we would appreciate if you would fill out the evaluation survey provided at the end of the session. Thank you for joining us today, and we look forward to welcome you back in the future webinar. Thank you.